Good morning, all. So I am for the yes of these cardiovascular manifestations of diabetes in women. Are they different? So next, my another colleague will come and say rebuttal of whether they are no or what. So we all know that diabetes increases the cardiovascular risk for everyone. Naturally, there is a cardiovascular protection in the premenopausal women, as the hormone says. But despite of this, higher relative risk of the mortality and severe complications in women than men. So basically, these are the some of the differences when diabetes in men versus women. Relative risk is increased higher in men, but significantly higher in women. And vessel type, like cardiovascular is a macrovascular disease, like ACS, acute coronary syndromes and all. But in men, it is usually the larger epicardial arteries, and in the women, it is microvascular type of involvement. So when it comes to the heart failure type, in the men it is mainly the reduced ejection fraction, and in the women it is preserved ejection fraction type. And symptoms, so usually they are very classic, typical in diabetic men, but in women it is atypical and silent. These are the basic factors so that we can say these normal manifestations of cardiovascular system abnormality in diabetic women. So the higher relative risk of the mortality and disease, this all we know, that diabetic women have a higher risk of mortality from CAD compared to diabetic men, one, and stroke is also 27% greater risk when compared to diabetic men, and heart failure, which is a stronger predictor of the heart failure in the women. Diabetes is a stronger predictor, increasing 5 times more common in women when compared with the men, that is 2.4, almost double. And this loss of protection, diabetes acts as a modifier that eliminates the lowest risk of cardiovascular disease usually seen in non-diabetic women. So there is a unique pathophysiology also. If the diabetic cardiomyopathy is there, women are more prone for the diabetic cardiomyopathy. And the cardiac remodeling, usually in the women, it is something like a concentric LVH leading to HFF, that is heart failure with the preserved ejection fraction. But in the men, it is reversely, that is eccentric hypertrophy leads to dilated cardiomyopathy type, and it is most commonly heart failure is with reduced ejection fraction. So severe risk factors will be there, other risk factors like dyslipidemia. So the higher triglyceride levels and lower HDL is more common in women, and prothrombic state also. So diabetic women exist the higher platelet reactivity and increased fibrinolytic and thrombotic factors, creating a more prothrombotic clotting prone environment in the women. So different clinical presentations, atypical symptoms are more common in the women, because it is not a like chest heaviness, but it may be a pain in the jaw, pain in the neck, pain in the shoulder. So all angina equivalents are more common in women than in men. Though there is also silent episodes of acute myocardial infarction or acute coronary syndromes. So there is also because of this there is a diagnostic delays. So there is a lower index of suspicious, and there is often a longer delay in the diagnosis and the initiation of the treatment. And there is also treatment delays. Under treatment is possible, metabolic differences are there. So particularly a shift from the pre-diabetes to diabetes is more sudden in the women, particularly it happens after the menopause. So the hormonal interactions are also there. So this protective effect is gone, then this diabetes accelerates the vascular damage, leading to other complications. So key differences in cardiovascular manifestations are like IHD, later onset in the women, but more non-obstructive type. So heart failure is more preserved ejection fraction type. Hypertension is higher BP in the men until menopause, and then women is equivalent to the men. Then aortic sclerosis, degenerative aortic sclerosis is more common in men. So stroke and cardiac, women more thromboembolic cardiac strokes with greater disability and higher risk than men. And aortic disease, abdominal aortic aneurysms are more common in men, but rupture is more common in the women. So like this, these are the various differences. This is one study showing these great differences. So in women, so 50% higher risk is there, I just eliminated, but this study says that pre-diabetes and undiagnosed type 2 diabetes are associated with the greatest risk for the cardiovascular disease. So in this study, almost 20,000 patients, 18,745, and so this is depicted more in the figures. Like the median follow-up of up to 18.6 years, pre-diabetes versus risk of atherosclerotic cardiovascular disease were significant in women than men. That is, hazard ratio is 1.1 versus 1.08, but that is statistically significant. But association between undiagnosed type 2 diabetes is not a statistical significant in the study. And so here you can see that CHD, stroke and ACVSD hazards ratio, men versus women in each category. So all these series, so women are more risk for the developing these complications. So that is for pre-diabetes. For undiagnosed diabetes, so there is a little difference. This is the only thing where we can compare men with women with diabetes in this point of view. So key cardiovascular manifestations, heart failure is one, atypical chest pain syndromes, silent heart attacks, and autonomic neuropathy will cause all these resting tachycardia, postural hypotension with atypical symptoms are more common, including the exercise intolerance. So in conclusion, pre-diabetes and undiagnosed type 2 diabetes is associated with the greatest excessive risk for the cardiovascular disease in women than men. So need a specific, sex-specific, gender-specific guidelines in type 2D screening and treatment. Combination of more metabolic burden, more severe vascular damage, atypical symptoms and less intensive treatment leads to much higher and often fatal cardiovascular burden in the women with diabetes compared with the male counterparts. So to close this gap, the need more sex-specific data, higher clinical suspicions of the heart disease in any woman with high HbA1c, and regardless of whether she has a typical chest pain or not. So debate is better should shift from are there different symptoms or how we do treat them differently. So I'll stop here for rebuttal by my other co-speaker. Thank you very much for your presence here.